So welcome everybody to tonight's My Macula and Me. My name is Cathy Yelf and I'm the Chief Executive of the Macular Society. Now tonight, for a change, we are discussing some possible new treatments and what they might mean for people with dry AMD. Now, geographic atrophy is a name for the advanced form, really, of dry AMD, dry age-related macular degeneration. And as you will know only too well, there are no approved treatments and therapies for dry AMD, geographic atrophy, at the moment. However, for the first time, two possible treatments have reported positive late-stage results and may even be available in clinics in the next 1 or 2 years. Now, of course, in many ways, this is enormously exciting, but these treatments have to be given as an injection into the eye. And that's what we're going to talk about tonight. We have some very eminent guests with us this evening. Dr. Christiana Dinah is a consultant ophthalmologist who leads both the macular service and ophthalmology research at the Central Middlesex Hospital. And she's also the ophthalmology specialty co-lead for the National Institute for Health Research Clinical Research Network in the northwest of London. David Crabb is Professor of Statistics and Vision Research at City University of London, where he runs the innovative and hugely respected Crabb Lab. And Jamie Enoch is a research fellow and PhD student, also at City University of London, with an academic background in psychology. Now, his research uses interviews and surveys to explore the psychological and social aspects of living with an eye disease and visual impairment. Now, what we're going to be talking about tonight are these expert guests' research that they are doing that is focused on understanding what we call the lived experience of people with geographic atrophy and whether these potential new treatments delivered by eye injections would be acceptable to them. Now, the aim is to develop insights, really, that would influence how the services for people with geographic atrophy are planned, and if these services and these treatments are approved and the future of drug development for GA progresses, how that should be done and what patients would find acceptable and not acceptable. Now, we want to hear your views about this tonight. So I know that lots of people often want to ask questions about their own condition in these sessions, and I hope we'll get time to do some of that. But really what we want you to think about really hard tonight is what would you want from a service if you had dry AMD, geographic atrophy, and a treatment was suddenly becoming available? What would be acceptable to you and what would not be acceptable to you? We want to talk about that tonight. Now, the way to do that is through the chat box. The chat box is open, and this is how we'd like you to ask your questions or make your points by clicking on the message icon. You then type in the box and then press send. Now, that's the best way of doing it for these webinar purposes. But if you really can't do that, then you can raise your hand, a little icon, yellow icon, raising your hand. And that means we can press the magic button that allows you to speak and ask your question that way. But if you can use the chat box, please do. It's the most efficient way. So over to our experts. And I'm going to hand over to Christiana first of all. Christiana, David and Jamie, welcome. And over to you now, Christiana first.
Thanks, Cathy. Thanks for a fantastic introduction. I couldn't have said it better myself. That's exactly the point. That's why we're here, to understand patients' perspective. And our group, you know, I say our group, David obviously is an eminent professor in this field, and we've just started working together in the last 2-3 years. But our focus really has been trying to understand the patient perspective. I'm going to share my slides. There. Sure. Can you see my slide?
We can.
Okay, right. So I've been an ophthalmologist since 2005, and in that time, seen thousands of patients with geographic atrophy. And I feel like, particularly over the last 5-6 years, the question to me, oftentimes from our patients, is, are we there yet? Is there anything yet? There's been a lot of development with wet macular degeneration. And yes, whilst that's not perfect, we now know that the development over the last 20 years has reduced the loss of vision from wet macular degeneration by 30 to 50% globally. So those treatments, those injections have had a significant impact, and geographic atrophy sadly has lagged behind. So are we there yet? I wanted to show this slide because I think it nicely illustrates what the majority of patients with geographic atrophy have, and that is an area, as Kathy rightly said, it's an advanced form of dry macular degeneration, and the yellow patches you hopefully can see there basically suggest where there's loss of cells, and it's away from the center of the eye, and slowly over time those patches increase until they start to affect the very center of the eyes. So dry macular degeneration, we normally say to our patients, or we have said over the last 15, 20 years, that's the good type. The wet type, you need an injection for. But obviously, we're aware that even though the dry type is slow to progress, it does have an impact on vision even before it affects the center. And David will be talking to us a little bit more about that. But also, at some point over time, in many patients, it can affect the center and impact their vision. So if you have a look at this graph, and this graph probably will help to understand what the new treatments we're talking about are aiming to do. What we know from this graph, or rather what I'll explain, is that currently, as I said, geographic atrophy slowly gets worse over time. And if we can slow the rate at which it gets worse, then hopefully we can actually delay it enough that it never affects the center of the vision. And by how much we can slow it down is really the study of the subject of trials, and also if we can even maybe one day reverse it. The current trials that Kathy mentioned before, the 2 late-stage drugs, they're good news because we now have treatments that have gotten to the essentially final stage of clinical trials and are now being discussed about coming into the clinic. And they've demonstrated equivocally, very clearly, a better response, a slowing down of progression over time. So those numbers might not mean much to many people. They're basically telling us that those drugs over 18 months, and now we even have 24 months, so 2-year data, they're telling us that basically we can slow down with injections either monthly or every other month by about 17%. Now, the purpose of the work David and Jamie and I have been doing is to try to firstly understand whether these injections will be acceptable to patients. We didn't think that most people would be able to translate 15%, 20% to their own personal experience. What does that mean for me if I've got geographic atrophy and you can slow it down by 15, 20%? So we wanted to tease that out from our patients and try to understand what is meaningful to them, how much of a slowing is meaningful to them, and what factors affect whether these treatments are acceptable. Because our feeling is that if we understand this better, then we will be in a better position to ensure that the service delivery or the way we provide these treatments to our patients is acceptable. And also that information can be fed into development of this current treatments, but even other treatments along the line. So that's just setting the scene as to why we decided to do the work. And I'll introduce David, who will talk to you more about how geographic atrophy can affect vision, both in the center and beyond. Thanks, David.
Thanks very much, Christiana. I'll share my screen now. So,
should I stop? Also, I need to stop share, I think. Yeah.
Yeah. You can see my screen okay now? You can see it, yeah?
Yes.
Good. Yeah. Well, first of all, thanks, Christiana, and also thanks so much to Kathy for putting together this symposium. I'm so impressed by how many people are here, and it's good that it's not going to clash with I'm a celebrity comes out here in the jungle. So hopefully we'll finish on time. So yeah, very briefly, a little bit about what I would like to talk about and where I'm from, really. So let's just make sure this is going on. Right, so I'm based at City University, London, and I work in a school of optometry. And for your audience, Kathy, anyone who sort of maybe lives in the southeast or in London, and if they've been to what we call an optician or a community optometrist in their time, then it's pretty likely that they would have been examined by an alumni or someone who's been trained at City University. We're one of the oldest optometry schools in Europe, actually, and we train around about 100 to 120 optometrists every year. So that's where I'm from. And we also, when we're not teaching, because that keeps us very busy, we also try to do some research as well. And my research is interested in sort of measurement techniques in vision. And again, for your audience, Kathy, what this means is that I'm interested in what happens when a patient or a person goes to their community optometrist, or when they go to their hospital eye services. You have these ophthalmologists like the brilliant Christiana, and you have optometrists prodding and poking and photographing the back of the eye and getting you to measure things and pressing buttons. Well, all of that stuff is what I'm really interested in as a researcher. So the way that we measure vision, that's what we're really interested in. And I'm interested in measuring vision in different eye conditions. So things like uveitis and glaucoma and age-related conditions like cataract, glaucoma, and age-related macular degeneration. And about 5 years ago, we started a program of work in non-neovascular age-related macular degeneration, which is dry AMD. And we started this program of work as you should start any program of work, and that is to really speak to the patients or the people who are affected by this condition. And in a series of sort of interviews, we tried to find out about what the experience of living with the non-neovascular, the dry form of AMD is, and what the experience of those patients were. And I've put like a little QR code there, because it might be that some of you might want to read this article. It's not really bedtime reading, but at the same time, I think we've probably got many people in the audience with dry AMD, and you will probably empathize with a lot of the kind of commentary and a lot of the stories that we reported in this article. But the main reason I'm showing you this article is in the title, because this is an actual quote from one of the patients that we interviewed. And this was something that was said to her when she was diagnosed with dry AMD. The consultant who eventually diagnosed her said, "You've got dry macular degeneration, end of story." And he went on to say that at that time, there is no treatment for slowing down the progression or the worsening of this condition. And that has been the case for a long time. And this is, really something that is a really kind of a blow to anyone who gets a diagnosis of a condition or a chronic condition, because to be told that there's nothing that anyone can do for it is probably, a really awful feeling. And that came across in this patient's nice commentary. But as Christiana has said, we're actually on the precipice now, and that's a very posh way of sort of saying we're just about to have some new treatments for the non-neovascular or dry form of AMD. And these treatments sound very complicated: complementary inhibitors, pegaseptcopalan. All of these are very complicated, but they have to be administered by injections. And that's what the brilliant Jamie Enoch is going to talk about in terms of our AGAIN project, because we want to know, well, are patients going to kind of trade their kind of experience with their condition with the treatments that might be available. So as I said at the beginning of this little short part of the session, Christiana, I'm interested in all the measurements that we take in the clinic. But what really matters to the patient isn't the kind of measurements that I would take or an optometrist or an ophthalmologist would take. what the patient wants to know is, you know, how their vision is going to deteriorate such that it's going to start to impact on their everyday life or their vision related everyday life. So, you know, when's their dry AMD going to get to this stage that Christiana has explained, geographic atrophy? Because when it gets to that stage, then it starts to have an impact on reading. It starts to have an impact on a person's ability to carry out any kind of task, maybe just finding something, you know, on a kitchen cupboard, for example. When does the vision deteriorate such that it starts to affect a patient's mobility or make them start to think about, you know, the risk of falling? And something that we know everybody or many patients are concerned about, that their vision is going to deteriorate such that they can no longer drive. So as part of this program of work, we've done a whole series of studies in this area to try to highlight, I guess, Christiana, to try and highlight the issues that people have with geographic atrophy, this advanced stage of dry AMD. So in particular, you know, this was something that we were particularly interested in, how well patients can search for things in everyday life. So, you know, I'm sure throughout today, you know, you've had to kind of search for something. It might have been something on a supermarket shelf, or it might have been just trying to find, you know, a sign in a bus station, or you might have been out and about and you need to find the name of a restaurant. You know, this is something that we do regularly, and we know that patients with this advanced form of dry AMD, even if they have what we call preserved visual acuity, which is just like a complicated way of saying, you know, what your vision is like with glasses. Even if we can correct your vision for that, we know that patients with advanced AMD have these problems with these bits of their vision that are missing. And in particular, this does impact on how they can find and search things. Something else that we know patients talk about having problems with is face recognition. On my slide here, and hopefully for those who can see this slide, you know, there's a nice quote from one of the patients talking about how distressing it is that she's never again going to be able to see up close the entirety of someone's face. Another one of our patients talked about the kind of social disability of not being able to recognize faces immediately. You know, when she was walking around in her local town, you know, there was people that she sort of knew walking towards her and she couldn't recognize her face. So what we did in this study is we actually brought patients into the university and measured their performance on these face recognition tasks. And once again, this research sort of showed the problems that people have with the advanced form of dry AMD, this geographic atrophy that Christiana mentioned. And the other kind of aspect of vision-related quality of life that we looked at was mobility. And I'll just spend a little bit more time on this particular kind of project that we did, or this little study that we did in patients, because I think I'm hoping that this will resonate with some of the audience. And this was the kind of anxiety that patients have with general mobility. So what we did is we were like film directors. We shot all these films around London, in and out of shops, on transports, buses, walking around, and we shot these films as point of view, so that, you know, you're looking at this as though you're actually within the scene. And if you look at the video carefully, you can see that the participant is looking at one of these videos. And in front of the participant, there's this like big red button, which we asked the participants to press when they feel as though they're looking at a scene that's kind of giving them anxiety. So it's a bit like one of these big red buttons you see on a Saturday game show, you know, like the kind of thing that Simon Cowell has in front of him. And we asked the participants to press this button when they had sort of anxiety. And then to show you what the results look like, this film here is again one of these films. And along the bottom of the film, you can see these kind of lines, hopefully. And the red line represents the pressure of being put onto the button by all of these patients with the advanced form of dry AMD. Remember, this is this geographic atrophy that Christiana mentioned. And you'll have noticed as you were looking at that film, as the participants are kind of being guided down the stairs, as it were, or the steps, you can see that the red line kind of dips down, which kind of really nicely captures the kind of anxiety that patients have when they have this more advanced form of dry AMD. And I'll just show you one more example of this. Again, you know, a lot of the kind of measurements that we take in the optometry clinic and in the ophthalmology clinic are always done in rooms like this, you know, very bright lights. But we know that patients with AMD struggle with different lighting conditions. And this was a really nice example of not just the kind of anxiety that people have when they're around, you know, doing mobility tasks in the dark. But as this bus appears now, you'll see the glare of the bus lights. And you'll have noticed that hopefully this little red line that dips down represents the anxiety of the patients as that bus is approaching them. So we think these films are a nice way to sort of highlight the kind of anxieties and worries that patients have because of their vision and because of how it's affecting their mobility. And because we're kind of scientists, we can go on and kind of quantify this. And we do this in a way of sort of capturing all the information from these recordings. And what we showed in this work is that patients with the advanced form of dry AMD, you know, definitely have a different kind of profile in terms of the anxiety that they have with these mobility situations. And again, this is a paper that we call it's open access. So if you wanted to read this paper, then there's a QR code there that you can scan and perhaps read that paper. And if you're interested in any of our research that we do at City, then you can also try and find us on sort of social media, or we're on Twitter as well. But hopefully that gives you an idea about what we've learned about the kind of problems that people have with this advanced form of AMD. But I guess now what I think Christiana and Jamie are going to talk about really is the study that we're embarking on to see, well, what about the new treatments, and are these new treatments in particular, you know, going to be acceptable to patients?
Thank you. Jamie, are you going to share a slide?
Yeah, I'll just start sharing now. Right, are they showing okay? Let me see. Thanks so much. Thank you, Christiana and David, and thank you, Kathy, as well, for the invitation to be here. And thanks very much to you all for joining today. So yeah, it's a pleasure to be here and speak about our study that Christiana introduced before, the AGAIN study. And it's an exploratory study that we've been working on to consider the perspectives of people with geographic atrophy about these new injection treatments, and consider how acceptable people with geographic atrophy find these new injection treatments. I should say before starting that the study was funded by a grant from City University, and then in the later stages by the pharmaceutical company Apellis, who are developing one of the new treatments, APL2 or pegcetacoplan, it's hard to say. And so obviously the funders are interested in the study results, but they haven't had any role in the study design or analysis or publication. So our study's objectives were firstly to understand what people living with geographic atrophy think about these new injection treatments. Essentially, would participants in the study take up treatment if it became available, say, tomorrow through the NHS? And secondly, we also wanted to understand which aspects of the treatment patients were concerned about. Which aspects of the treatment patients were hopeful about, but also what they were concerned about and what could potentially be improved upon in future drug development efforts or through innovative forms of service delivery. And we also kind of started to consider tentatively whether certain factors such as a person's age or the severity of their vision loss might affect their views on the treatment's acceptability. So who participated in the study? So 30 participants with geographic atrophy volunteered to participate, recruited from 2 medical retina clinics in Brent in London. The average age of participants was 83 years of age, and about 2/3 of the participants were female. The sample in our study was relatively ethnically diverse as well, with 63% of participants identifying as white, 27% as South Asian, 3% as Black, and 7% as another ethnicity. And 63% of the participants had prior experience of eye injections for wet AMD, while 37% had no previous experience of eye injections. So what did the study entail? Firstly, we asked participants questions about demographics, so things like their age, ethnicity, gender, education level, but also whether they had eye injections before. We then asked some simple questions to get a sense of participants' overall general health. And then we provided a recap of information about the emerging injection treatments in the pipeline. And then after discussing this information, participants responded to a series of structured questions with preset answers on a kind of 1 to 5 scale. So these would be things like, based on what you know now, would you be likely to have the treatment if it was offered to you tomorrow? And then on one end of the scale, there was an option of extremely likely, and on the other end of the scale, there was an option of not at all likely. So those were the structured questions that we asked participants. And then participants took part in a more open interview where they responded to more open-ended questions and could speak freely about their experiences and perspectives. So here we asked participants questions such as, what do you think would be the main benefit to you of the treatments we've described? And we asked participants as well, does the fact that treatment will slow down vision loss, but not improve vision, put you off the idea of committing to long-term injections? So what did we find? So analyzing responses to the structured questions and to the semi-structured interview, we found that 60% of participants would accept the treatment at any cost. Meanwhile, 27% were more ambivalent or unsure, and 13% of the participants were deemed to be unlikely to proceed with treatment if it became available. So the name of this first group, comprising 60% of participants who were positive about treatment, was derived from one participant, and she stated during the interview, I think I would have treatment at almost any cost. And for this participant and for other people in that group, the underlying motivation was to have a longer amount of time to continue with vision-based daily activities such as reading or family, social, leisure, caregiving activities, etc. Another participant in that positive group stated, I might be worried about the needle, but it's got to be done. Everything is falling apart. So that quote, very starkly shows the fear that a lot of people might have about undergoing injections in the eye, but it also shows how keen that participant was to have some kind of treatment for her geographic atrophy. And a third participant stated in the positive group among the 60%, if I could keep whatever vision I have, that would be very excellent. If you can stop it there and it doesn't get worse. And so this quote is interesting because it shows that even though during the study, we discussed several times that the treatment will slow down, but it won't stop and it won't reverse geographic atrophy. Some participants' positive attitude towards the injections might have been linked to a belief that the treatment could in fact stop geographic atrophy progression, which it can't. So I think this points to the importance of sort of education and counseling to accurately set expectations before anyone initiates these treatments, to make sure that people with geographic atrophy understand that it will slow down but not stop or reverse vision loss. So across the participants who were a bit more unsure or a bit more negative about treatment, there were concerns and doubts about the limited effectiveness of the treatment in that it will only slow down but not stop or reverse vision loss from geographic atrophy. So one participant very bluntly stated, is that the best they can do, slow down the process? And another participant stated, it will not bring back the lost vision, so I think I will not benefit from it. And several participants shared that view, thinking that treatment wasn't worth it for them if it wasn't going to restore their sight enough to continue with vital daily activities that they were already prevented from doing, such as reading or driving. And then at the other end of the spectrum, a view came from quite a small number of participants who felt that the treatment would do nothing for them because their functional vision was currently good. And so they didn't necessarily see the preventative value of the treatment. So for example, one participant stated, I do not want my eyes to be affected in any way. At the moment, I'm quite happy. I can read the newspapers and everything. So there's no point in taking injections. So again, if these drugs do get approved, they'll might be need to raise awareness that the sooner someone starts on the treatment, it's more likely that the outcomes will be better. And And a second area of concerns related to the fact that the new treatments for geographic atrophy slightly increase the risk of developing wet AMD in the eye being treated. So this risk, as well as the potential for other side effects from the eye injections, was understandably very concerning for several participants. For example, one participant stated, "I would want to have longer vision, but I'm concerned about the risk of wet AMD." And another stated, "The eye is a very delicate place. I'm worried something can go wrong. I will try once, and if nothing bad happens, I will carry on." So this participant was essentially saying that if they did have, significant side effects from the injections, then that might cause them to discontinue the treatment. And finally, study participants were often worried about the prospect of regular monthly trips to the eye clinic and waiting time once they were there, for both themselves and, if applicable, for any accompanying relatives or friends. So one participant stated, "Coming to hospital, if it's once in 6 months, is okay. It doesn't matter. If it's frequent, then that's going to be a problem." And another participant stated, "When my mum was having injections, they used to come and pick her up in the morning at 9 a.m. and sometimes she didn't come home till 6 o'clock. She had to sit around for hours waiting for transport. This is what will put people off." So we also asked participants how they felt about having the injection treatment at different time intervals. So we asked them the question, based on what you know right now, how likely would you be to have eye injections to slow down progression of your GA, or geographic atrophy, every month, every 2 months, every 3 months, and every 6 months? And the chart shows that for injections every month, 10 participants were fairly likely, so that's shown in the mustard yellow bar, and 9 were extremely likely, and that's shown in the lilac or pale purple bar, to have injections once a month if these became available. But less frequent injections were clearly more acceptable to participants, with 15 of the 30 participants saying that they were extremely likely to have injections every 2 months, versus 9 out of 30 saying that they were extremely likely to have injections every month. So it's important to note, and Christiana was showing some of this data before, that the treatments in late stage clinical trials now are offered every month or every 2 months. And our data suggests that every 2 months is probably more acceptable to most patients. And the data is also showing that there isn't necessarily a big difference in terms of the treatment's effectiveness if it's given monthly or every 2 months, sorry. So in summary, a majority of participants in our study were quite positive about treatment, despite the burdens and drawbacks. There were some misunderstandings about how or whether the patient would experience the benefits of treatment. For example, with some participants expecting to see their vision loss being stopped or halted by the treatments. Key concerns about the treatments were clustered around 3 main areas. So the effectiveness of the injections, the fear of side effects and wet AMD, and the logistics of regular eye clinic visits. And hopefully this knowledge of patient concerns will allow our team to consider how these issues could be addressed if the treatments do get approved and rolled out. And so our next steps, and I think Christiana's going to talk about this, is to undertake a UK-wide survey of 300 people with geographic atrophy. Because I should say that these findings are based on a sample of 30 people, so and it was an exploratory study. So thank you very much for listening. I'll hand over to Christiana to talk about the next steps. My email is here in case anyone has detailed questions on this work. It's Jamie, JAMIE.enoch, ENOCH.2, the number 2, @city.ac.uk. And there's also a QR code to scan if anyone would like to read a draft of our paper. This draft is what's called a preprint, so it hasn't been scientifically peer reviewed. So the findings should be taken with a pinch of salt at this stage. But thank you very much for listening and for the chance to speak.
Thanks, Jamie. So I'm just going to wrap up this by just talking about the next steps of the project that Jamie has so succinctly and eloquently described. So we call this project the AGAIN project. I suppose from our perspective, AGAIN means, there's been the introduction of injections in 2006 for wet, and this is essentially reintroduction of injections now for the geographic atrophy, which is the advanced dry type. We call this work program 2, and the aim really is to understand whether, exactly as Jamie said, whether this regular injections will be acceptable in a larger population of patients, and what, if anything, we can actually modify to make them more acceptable to patients so they can have the benefit. So we call that work program 2, and the objectives are as described. So what we plan to do with that, again, similar to what Jamie said, is we'll basically give our, we have patient advisors. There's 6 to 8 of them who look at the results we've just presented to you and how we transform that into quick tick box survey. And then when that process has been done, we'll share that with geographic atrophy experts across the country for their input and their experience, because when you've treated patients with geographic atrophy, there are things that will matter to them that you might want to say, oh, you've missed that in this questionnaire. Then we'll move along and test out this quick survey on a group of 10 patients with geographic atrophy to ensure that the words we use are free from jargon and words that are, just medicalese, as we say, and actually more words that patients understand and address your own concerns. Then when the questionnaire is finalized, we will roll it out across the country, 300 patients with geographic atrophy across 10 sites, and we will basically do 3 steps. We'll check their vision in the clinic, not in the fancy way that David has shared, but more in the typical controlled manner that we would do in clinics. Then we will do the scans, a couple of scans, and then we'll run a couple of questionnaires, including the one we've just developed. And basically our aim would be to do that in this 10 sites across the country. So from Bristol to Sunderland to Newcastle to London, Nottingham, Southampton, Wales. And then the outcome, what we aim to get from this is how many patients, or the proportion of patients that find these treatments acceptable, what specific things would they like us to change or could be modified when we roll it out. We've already heard from Jamie that going from monthly to 2 monthly seems to make a big difference. Will that be the same when we do it in 300 people? Because if so, we then need to look at the data from the clinical trials and what the risks and benefits of monthly versus bi-monthly are, and then that helps make those decisions. Because ultimately, if patients will not have the treatment monthly, for instance, and are less likely to not attend appointments, are more likely to not attend appointments, but on the other hand, if they will attend bi-monthly, is there a loss in terms of how well the drug works? But also, is there a reduction in side effects the less often you give it? So those are the sort of things that need to be balanced. Then also, finally, we would look at our data basically will help to steer scientists in terms of future drug development, because we understand and are sure that patient acceptability absolutely influences how well patients adhere or stick to the plan for treatment, which then affects how well the results are for the patient. So it's really important that when we're designing these treatments, that patients are at the very center. So it's question time. I think we've got like 20 minutes. So that's, I think, a lot of time to answer some of your questions. And I can see there's a lot of questions in the chat. Thanks, Kathy.
Thank you very much indeed, Christiana and David and Jamie. Thank you all very much indeed. I'm sorry, my camera didn't seem to be working at the beginning. Is it working now?
Yes.
Hurrah.
Yeah.
Okay, so if you would mind
yeah.
stop sharing, that's fine. So yes, so something I just want to clear up right at the beginning. So we've got these phrases: early AMD, late AMD, geographic atrophy. So actually, somebody put the question really well. At what point does early macular degeneration become geographic, or what point does dry AMD become geographic atrophy? And I suppose what we're talking about here is that there's a long period of maybe of many years when there are the early startings of the beginnings of the disease, but people have no symptoms, they don't notice it in their vision. So when you're talking about geographic atrophy, are you talking about the point at which vision starts to be affected? Is that what we're talking about here?
Not quite. Basically, with dry macular degeneration, you have the waste products that are deposited at the level, at the very base of the retina, which we call drusen. and the photoreceptors, which are the cells that help you see, translate light, are lying essentially over that side, over that area. Geographic atrophy starts to happen when those cells are lost, when the cells, those photoreceptors over the basement of the back of the eye are lost. Now, because it can happen away from the center, you can start to develop geographic atrophy away from the center and not be aware that you've got it. So it can feel like dry AMD because essentially until you've got something affecting the very center, or sometimes, like David said, sometimes it's not affecting the center, it's affecting things like how contrast, so how you see things in dim lighting and so on. But you can, that happens even with dry AMD, but many of us compensate. We find ways to live with it, so we don't necessarily notice. Even dry types of, some elements of dry AMD can affect your vision. So geographic atrophy can affect your vision, but oftentimes if it's small and away from the center, many patients don't even, they're not aware of it. Particularly if, for instance, it starts off in one eye, the other eye is absolutely fine. You can actually go around feeling like your vision is fine, but you still got geographic atrophy. So the term geographic atrophy really is essentially describing a structure, not the symptom. Dry AMD and geographic atrophy, those are all just basically things we see on images. They don't necessarily describe how you experience your vision. If that's helpful.
Yes, that's very helpful. So are we saying then that these potential new therapies would be available for people who may actually not have, as you say, the center of their vision being affected as yet, but they are potentially targets for these therapies?
Absolutely,
yeah.
Absolutely. That's very correct, and that's why I think it's difficult for or people aren't sure, even the clinical community isn't sure how our funders, the health payers, NICE, would sort of assess it, because we're used with eyes, with retina, we normally, the golden standard is how much visual acuity or lines on a chart really is how we measure the benefit of a treatment. But with this, we're not using that because your vision could stay the same for the entire 2 years. The point is, it's not getting worse. The patch is not getting worse. So it's a different way of looking at things, which means the way we educate patients has to be different. With wet AMD, you maybe might have a patch in the center of your vision. With injections, that patch maybe gets smaller or things get less wavy. With dry, you probably won't have that feedback from the treatment. You would have to trust your physician, probably, who's showing you the images saying it's not, it was getting, bigger by this amount over the last 2 years. Now it's slowing down. So it's a different feedback. It's a different way of understanding how a treatment works.
And so it may be different. You're thinking that the patient's responses may be different from wet AMD, where very often people have quite noticeable changes in their vision, even between treatments, don't they?
Absolutely.
Sometimes. So, yeah. I mean, to put it crudely, there's a fear factor that may not be present so much with this early geographic atrophy. Do you think is that the risk? The patients will think it's not making any difference. I don't know why I'm putting myself through all this.
Absolutely. So there's that. Even with wet AMD, sometimes, most treatments with wet AMD, after 3 or 6, the first 3 or 6 injections, you get what is essentially usually a substantial rapid rise in vision improvement. And when you start to treat patients 2, 3, 4 years down the line, at that point, you're just maintaining vision. But sometimes patients feel, well, there's no difference for the last year. But the big difference happens early, and the rest of the treatments really is about maintenance. So similarly with dry AMD, well, it's really about slowing down progression. So maintenance, you won't have that rapid rise. So there is a worry that, or there's a concern, I guess, if we don't educate properly, that there will be the adherence or people deciding to stick with it might actually not be high, because they feel like, why am I going there every month or every 2 months? What am I getting from this?
So, Kathy, could I just sort of, if you don't mind, because I think a nice analogy for sort of dry AMD and Christiana is that it's almost like bankruptcy. that, you know, you can be going along very gradually and then, you know, your vision will tumble. And I think perhaps, you know, what these new treatments will help patients to avoid is that moment of sort of bankruptcy in their vision. That would be one analogy, is the way I would describe it.
Yeah, I think that's definitely one way to put it, in that you're elongating the time it takes to get to the edge of the cliff, but hopefully maybe stopping getting to the edge of the cliff at all, because what we hope is that, you know, with regular injections, that slope on that graph changes and the time to get to the very center is significantly lengthened. So you get more time to do the things you want to do. And what we learned from what Jamie said is a lot of it is a lot of reasons why our patients want to have this treatment is they want more time, as much time as possible, to do the things they would like to do, or the things they enjoy doing, what we call vision-related activities. We all take for granted the searching, the walking, you know, all of that stuff. They want time to be able to do that, and if this treatment provide that, then that's a win, and that's a step towards getting there.
And people have very good reasons, don't they, for being desperate to hold their sight. So somebody earlier on in the chat talked about being an informal, unpaid carer for no fewer than 3 people who rely on her to look after them. And somebody, Patrick, has just put in the chat, his central vision is affected, but he's just above the driving threshold, has face recognition problems as described. Would this treatment help?
We would, so if the vision is 70, yes, you would hope that what would happen with this sort of treatment is that suggests to me that the center of the vision, which we call the fovea, might be affected, but maybe not drastically so. So you would hope that with regular treatment, we're able to maintain those photoreceptors and things slow down, such that however long it would have taken to completely lose the photoreceptors, it takes much longer to do so. So he would be, without looking at scans, just in general, just those numbers suggest to me that yes, he would potentially benefit from elongated time with the treatments. I suppose if we look at the trials, they did, you know, from a vision perspective, essentially we can say people with vision like his were in the trials and they were showed to benefit. So you can expect that this is the sort of person that would benefit.
Is it possible to say how long? I mean, I guess people's experiences of macular disease are very individual, aren't they? So I guess, is it possible to say how long people might see a slowing down? How long the effect of the drug lasts, I suppose we're saying.
Right. What we tried to do, what Jamie tried to do was try to understand how can we translate this 20% and so on to time. So we sort of said, look, the average time to the center, and the problem with geographic atrophy is that different people progress at different rates. So there's some people who are very slow progressors, and I see them in our clinic a lot. Then there are those, and by that I mean the small patch doesn't become a bigger patch, doesn't get to the center for 7, 9, 10 years. Then there's those that progress quite rapidly, within 2 to 3 years is at the center. And there is an average of somewhere between 5 to 7 years. So we thought if it's 5, let's call it 5 years on average to get to the center. If you have a 20% extension on that, 20% of 5 years is, I think, a year. So then you have an extra year. So that way you can explain 20% in time. And that way we feel the patients are better able, because, you know, 20%, what does that mean? I think being able to translate it to time is one of the ways we were able to understand, we were able to gather the thoughts of patients in this study, because we were using language that is clinically meaningful to them.
Another question has come up about this new treatment, about whether it would be useful for people who have wet and dry, because sadly they do coexist, don't they?
They do. Many people. Yeah. So, Jamie, did you? I'm happy to answer this, but you know, jump in if you'd like. Basically, one of the side effects of this treatment, and it's, you know, there have been many treatments for geographic atrophy that block complement and this is a complement inhibitor. It's just a long name for the chemical that it blocks. But one of the side effects in the trials was actually it slightly increased the risk of wet AMD. As you said, wet AMD and dry can happen together. And if you've got dry AMD, or geographic atrophy, there is already a risk of developing wet AMD, a background risk. And this disease is really, we say dry and wet, but they're really a spectrum, part of the same disease. So in the trials, we saw that those who didn't have treatment had about 3% of them developed wet AMD, and about 6% developed it in the arm that had the injection every year, and about 9% or so in the arm that had it 9% in the monthly, and less, so 6% in the 2 monthly. So actually, these injections can slightly increase your risk of wet AMD. That's a concern because, of course, wet AMD, we've always said it's a bad, it's not the thing to have. But on the other hand, we do have treatments for wet AMD. And if you're coming into clinic and having scans for dry or whatever, that means it will be picked up earlier and treatment started earlier. And we've seen that in patients who have wet AMD and then the second eye develops wet AMD. Because they're having treatments in one eye, the second eye tends to be picked up earlier. So the vision in the fellow eye or the second eye tends to be better longer term.
There are lots of people saying that they wanted to join up for the trial, which is good. So perhaps somebody could put in the chat. I don't know whether you're recruiting yet, but anyway, if there's an inquiry place that people can be signposted to, that would be helpful. We do have somebody with their hand up, Susan Turner. If we can allow Susan to speak, that would be lovely. The magic button wielder. Susan, are you with us?
Yeah, I am, but I don't know why that came up. I'm sorry, I didn't mean to press it. I must have pressed it at some point. And
do you have a question while you're there, just in case?
Not really. It's just that I was told that I'd got macular degeneration, but I'm really concerned because but I've just had the cataracts done. Does that make any difference?
Well, we were talking about that last week. Susan, thank you very much indeed for your question. Cataracts, again, this is something that happens. People have both things happening together, and it can be a worry about whether you should have your cataract done. But we were talking to somebody last month, month before last, about this. But what's your view on the cataract scenario?
I think if we're talking about wet macular degeneration, I always, and there's evidence suggest you should make sure the wet macular degeneration is stable, so it's treated. So because cataract surgery obviously causes inflammation and can worsen wet macular degeneration, but once it's stable and it's being treated, there's no problems having cataract surgery in that context, and we do that in a lot of our patients. I think there were concerns about artificial lenses and whether they block the sun, and whether having cataract surgery means you're actually more likely to get dry AMD and AMD of any sort. I think that the evidence there is equivocal. It's unequivocal. Well, it's imbalanced. There's no evidence that suggests that. So I personally would say, rather than leaving with blurred vision, have cataract surgery. Just make sure that the wet AMD is, if you've got wet AMD, that's treated and under control before you proceed to have cataract surgery.
Okay, thank you very much indeed. There's a question here about referral, about what point somebody would want an optometrist to refer a patient to a hospital eye clinic. Now, of course, this has become critical for wet AMD patients. What's going to be the situation with geographic atrophy patients? Will there have to be a whole protocol with these big urgent referrals, or how do you think that would probably need to be managed?
So David and Jamie, we did talk about this a lot in our so if one of you wants, because I've been talking all day, we've talked a lot about this, haven't we? And how this might go, and how we want to be able to influence how this goes, because it is important. Well,
I mean, the simple thing I would say, it's brilliant that, Kathy and the Macular Society have put an evening like this together, because I think, Kathy, that these new treatments that we're on the precipice of having are going to really change a lot of the way in which, you know, maybe optometrists work with ophthalmologists. And if we don't get our act together, then we're going to be faced with the same kind of situation and revolution that we had when we first had treatment for wet AMD. So I think it's a critical sort of time. And I think we have to be aware that the optometrists are very well-trained people. You know, optometrists can actually deliver some of these treatments now. And maybe going forward, I think making sure that workforce is, you know, embraces these changes is quite important.
I would agree with that. In my clinic, we have optometrists who inject. And I think that, and in fact, our lead, one of our lead injectors is an optometrist. So I think that is important. I also think that, you know, in terms of having a crystal ball, how would we like to see this happen? Maybe what we would like actually is that the patient is monitored in the community, because as we said, geographic atrophy gets worse at different rates depending on the person. So if you're seen maybe in January, and then in June, and then in December by an optometrist in your community, and then they can plot with a software how fast it's growing, and if it's progressing rapidly, then you get referred. But before referral, maybe you use our questionnaire, which talks about acceptability, so that they know whether you're keen to progress to have these treatments, and then you're referred to a clinic that knows that there's already a growth, and the patient is keen. It, like a shared decision-making tool, has discussion has happened with the optometrist, and so you're there for treatment. So that way, not, you know, we talk about this tsunami of patients with geographic atrophy that are coming to the hospital. This won't be necessarily suitable for everyone, because some don't need that treatment because it's very slowly progressing, or maybe not even progressing at all. So you really want to treat those who it is progressing and are keen to have treatment.
Lovely, thank you. We've got one more hand up. So if you could just pop the person onto the chat, onto the screen. Hello, what's your question? Hello, is it Brylight? Brilliant. I don't know how to say your name.
Yes, yes, okay, thank you. I've got pretty advanced AMD. Just to give us some quick idea, I need to read any sort of text at all. I need it blown up to about letters about 1 inch high on my iMac. Faces are a blur, but I'm about 4 or 5 feet away, so it's quite advanced. You were talking earlier about avoiding going over the cliff. I think I went over the cliff a while ago. Now I just stopped driving, you know, a few years ago. So what are the prospects of this new treatment for someone with fairly advanced AMD like me? You know, is it more effective in the early stages, or is it still beneficial later? That's my basic question.
Thank you very much. Thank you very much.
Thank you. In the trials, like any other drug, there's a definition of what the geographic atrophy that will be suitable in the trials were. And so there's a certain size, it's fairly large, but not too large. And so those who had very large geographic atrophy were excluded. That does not mean that that's what the funders, so in the UK, NHS, NICE, would say. So it would really depend on how they look at it. We think that from the treatment perspective, it may work better earlier. That's what the current evidence shows. Doesn't mean that it wouldn't work in, you know, larger geographic atrophy areas. It simply has not been necessarily tested in that, because very advanced was excluded. And you have to do that in a trial because you're trying to show the drug in as good a light as possible. But then once we have approval, we will then have to figure it out within our clinics, and what we call real world experience of who it benefits and how our patients take to it. And we've done that even with wet AMD. We treat patients that are out of what the trial designed, and I've published papers on benefits in people with what people would normally have given up on, and showing significant improvement. So it's possible. I wouldn't like us to not have hope before we've even gotten anywhere.
Absolutely true. Absolutely true. Look, I'm so sorry, we've run out of time, everybody. Jamie, David, Christiana, thank you so much for giving us your time this evening. It's been a very interesting session. It really has. You've got it in the chat how to contact the team if you're interested in finding out more about it. There were the marvelous QR codes. We've recorded this session, and in a day or two it will be up on our website and our YouTube channel, so you can watch it again if you think you might have missed anything or you want to go back over anything. And please let other people know. If you think you know other people who would be interested in this session, do please tell them where to go. Straight to the Macular Society website, and you'll be able to find all our webinars for the last 2.5 years there for you to watch. There is no by Macular and Me in December because it's right bang up against Christmas, the usual date. So we're going to skip December, but we will be back in the new year with some more fascinating and interesting webinars for you, and I hope you will join us then. But in the meantime, Christiana, David, Jamie, thank you all very, very much indeed for your time this evening, and thank you everybody for joining us. We'll see you in the new year. Thank you and good night.
Good
night.
Thanks so much, Kathy. Thank you to everybody there. Thank you.
Bye-bye.
Bye-bye.